Hello everyone, a very good day to all of you. So in this video, I will be mainly talking about important points related to early pregnancy module. So let's start. These are all the relevant GTGs which you need to be thorough with. And these are the NICE guidelines which you need to be very thorough. And yes, there are some other relevant sources which are important in this early pregnancy module, like best practices in abortion care, care of women requesting abortion, and these are the significant talks which you need to be well aware of. So now let's start with ectopic pregnancy module. In this, mainly you get scenarios, vignettes pertaining to the scenario of a lady presenting to you with ectopic pregnancy and various features they give, on the basis of which you have to choose the adequate management option. So like if a woman is diagnosed with tubal ectopic pregnancy, so first of all, you will have to see whether she is able to return for follow-up or not. If not, or if she is having any of the following feature, any one, either significant pain or persistent pain not responding to analgesics, or adnexal mass is of size 35 mm or more, or heartbeat is there on ultrasound, or her serum beta HCG is 5000 or more, then straight away you have to mark surgery as the first line treatment. But if she is able to return for follow-up and in whom all of these criteria are meeting, there is no or mild pain, the ectopic should be unruptured, adnexal mass size should be less than 35 mm, there should be no heartbeat on ultrasound, there should be no heterotopic pregnancy. Then you will look at beta HCG values. If the value is more than 5000, then obviously you will go for surgery. If less, then you have to classify in these three levels. If it is between 1500 to 5000, you can offer a choice of both, either methotrexate or surgery. That means you can consider methotrexate as well. If it is less than 1500, then you have to see whether it is in between 1000 to 1500. If yes, you can offer methotrexate as first line. Remember, offer methotrexate. Or consider expectant management. Not offer expectant, consider expectant, okay? But if beta HCG is less than or equal to 1000, then you can offer her expectant management if she meets all of these criteria, okay? But remember one thing, if the beta HCG levels, two values are given and they are rising, it is in a rising trend, then it's better not to choose expectant management as the treatment option. Hope it's clear, okay? Now, when you have chosen surgery as the first line treatment, then mostly laparoscopy should be performed whenever it's possible, taking into account the condition of the woman, the complexity of the procedure and the skills available. Like if she's in emergency and she's in shock, then laparotomy may be chosen, but otherwise laparoscopy should be preferred wherever possible. And yes, regarding anti-D, you have to give anti-D only in surgical management, not in medical or expectant management. Now, if there are no risk factors for infertility, you can choose salpingectomy. And in follow-up, if salpingectomy has been done, you can advise her UPT straight away after 3 weeks. If negative, well and good. But in women in whom risk factors for infertility are present, like PID, endometriosis, or other tube is damaged and she is desiring children in future, then you have to consider salpingotomy as your option. And in salpingotomy, what follow-up is to be offered? First, follow-up serum HCG at 7 days after surgery, and then weekly until negative. Okay, so in salpingectomy, straight away after 3 weeks, here weekly until negative. Now, when you have offered methotrexate as first line treatment, then what follow-up will you give? And in expectant, what follow-up will you give? Let's have a look at these. In expectant management, you have to repeat HCG levels at day 2, day 4 and day 7, means 3 times. First on day 2 after the original test, then on day 4 and 7, and drop between the two values should be 15% or more. If it is dropping by 15% or more, you are happy. Then you can go on repeating it weekly until negative. But if the drop is inadequate, that is, it is not 15%, then you have to review and seek senior advice. Or if an option TVS is given, you can go for TVS. Whereas when you have offered methotrexate, you have to repeat the HCG levels on days 4 and 7 post methotrexate. Remember, on day 2, 4 and 7 after the original test, on day 4 and 7 post methotrexate. And again, you will expect a decrease of 15% or more. If it is decreasing by 15% or more between day 4 and 7, you are happy. You can ask her to get beta HCG repeated weekly until negative. If not, then again you have to review and seek senior advice or a TVS. Okay. Now, sometimes there is confusion how to calculate the drop in beta HCG. So you should be very clear regarding this. Day 4 beta HCG will be more and day 7 beta HCG will be less. So calculate the difference between these two HCG levels, that is day 4 minus day 7, and then this amount is to be divided by the original beta HCG value, that is day 4 beta HCG value. Whatever comes, multiply into 100 to take out the percentage. For example, if day 4 beta HCG is 1500 and day 7 beta HCG is 1200, the difference between these two will be 300. You will divide 300 by 1500, that is day 4 beta HCG. So 300 upon 1500, that is 1/5, multiplied by 100, it comes out to be 20%. That means it's a satisfactory fall, and you will ask her to repeat beta HCG weekly. So this goes like this. And yes, prior to administering methotrexate, it's good if you get a urea electrolyte, LFT, full blood count and blood group done. And then you have to administer methotrexate. Now let's solve some questions based on this. Suppose a diagnosis of an ectopic pregnancy has been made on a 26-year-old woman at 7 weeks amenorrhea. She is trying to conceive since 3 years, PID is there, means risk factors for infertility are there. And her beta HCG comes out to be 6500. That means immediately your mind will start thinking we will have to go for surgical management. Yolk sac is there, no fetal heart activity, and even there is a history of previous ectopic and salpingectomy. So more so, first your mind thinks about which option, so surgery, and in surgery which one. So you will try to get a laparoscopic salpingotomy because infertility risk factors are there. Next, a 23-year-old woman, no significant history, persistent lower abdominal pain, bleeding. TVS is showing mass on the left adnexa, fetal pole and sac is there but no cardiac activity, and ecogenic fluid in POT. Means two things which point towards surgery, that is persistent pain and free fluid in pouch of Douglas. So your mind thinks about surgery. Now in surgery, which one? Laparoscopic salpingectomy. Why? Because there are no as such risk factors for infertility, so better to go for laparoscopic salpingectomy. Here, she is mother of one child, mild abdominal pain, irregular bleeding, UPT positive, serum beta HCG is 1200. TVS is showing an empty uterine cavity, adnexal mass is 34 mm, no fetal pole. Beta HCG is repeated and you find it to be 1400. She is hemodynamically stable. So now there are no suggestive risk factors which will point towards surgery. So let's think about either expectant or methotrexate. Now, since mainly you answer the thing which is offered, so between 1000 to 1500, you offer methotrexate as first line. So in this, methotrexate fits the best. Plus 2 beta HCG values are there and they are in rising trend. So the best answer here would be systemic methotrexate. The last one, she was referred to hospital with suspected ectopic, hemodynamically stable, lives close to the hospital, ready to come anytime. TVS is revealing adnexal mass less than 35 mm, no cardiac activity as no fetal pole, and beta HCG 1000. Means here we can think about expectant management. There is nothing which contraindicates expectant, so it's safe to choose expectant management. All right, now let's come to follow-up. A 31-year-old mother of two. She presented with abdominal pain, irregular bleeding. Pregnancy test is positive and TVS is showing left ectopic, some fluid in the pelvis. Following counseling, she went for surgery. Laparoscopic salpingotomy has been performed. So what would be her follow-up? We will repeat first beta HCG after 7 days, that is after a week, and then weekly till negative. So here the best answer will be beta HCG on day 7 and then weekly until it is negative. A 30-year-old woman, she presents with acute onset lower abdominal pain and amenorrhea of 6 weeks. UPT positive, ectopic, 1.5 into 2, no fetal pole, beta HCG was 1500, and she went for methotrexate treatment. Injection was given. So here what would be the follow-up? Beta HCG will be repeated on day 4 and day 7 post methotrexate, and then if drop comes to be 15% or more, then weekly. So we will choose the option which is closest to this, that is beta HCG on days 4 and 7, and then weekly until negative or less than 15. 33-year-old woman left unruptured. She went for methotrexate. Single dose methotrexate was given and beta HCGs were quantified. On day 4 it was 1500 and on day 7 it was 1350. Now let's calculate the difference. The difference is just 150. 150 divided by 1500. Okay. So here we can take out 150 divided by 1500 into 100. So it will be 10%, right? So 10% is an inadequate fall, right? We are not happy. So now we will like to reassess her further, or we can go for a TVS. So what would be the best answer here? Yes, transvaginal ultrasound scan, as the fall is just 10%, right? So these are the answers. So hope ectopic is clear. Now let's switch over to bleeding in early pregnancy. Now many questions come when the woman is tested positive. If any of the signs of ectopic are there, like tenderness, pelvic, cervical motion, abdominal, then you have to refer immediately for evaluation of ectopic and EPAS. But if there is no pelvic tenderness, otherwise, then you will have to look further. Now, if the woman is less than 6 weeks gestation and she is having painless bleeding, then you should remember what to do. You have to use expectant management. You can easily choose expectant management with an advice to repeat the UPT after 7 to 10 days. Remember this, 7 to 10 days. And to return if symptoms continue or worsen or UPT continues to remain positive. But if woman is having pain, her pregnancy is of 6 weeks gestation or more, or she is not sure of her last menstrual period, then you can't use expectant management and send her back. You have to refer her to EPAS depending on the urgency of the situation. So you have to always act according to this flowchart. Now, if heartbeat is visible, if any time intrauterine pregnancy is confirmed, then first you will have to check for a heartbeat. If heartbeat is there, good, you can continue routine antenatal care. If suppose she is bleeding with a visible fetal heartbeat, you have to advise that just wait for 14 days. And if in 14 days your bleeding subsides, continue routine antenatal care. Otherwise, further assessment will be required. So this is the basically flowchart for threatened abortion. Now, problem arises when there is no fetal heartbeat. Now next, what will you do? So for this, if you have looked for cardiac activity, if you didn't find one, then look whether fetal pole is present. If fetal pole is present, you have to measure its CRL, that is crown rump length. Now you have to act according to the size of crown rump length. If crown rump length is less than 7 mm on TVS, you have to advise a second scan, a minimum of after 7 days. If you are getting a CRL of less than 7 mm on TAS, you have to advise her a second scan after 14 days time. Okay. But if CRL is 7 mm or more, then either you have to seek a second opinion on the viability and or perform a second scan a minimum of 7 days after. Like in recurrent miscarriage scenario type of cases, there it's better to choose both, means seek a second opinion on the viability also and perform a second scan a minimum of 7 days after so as to provide her a margin. Okay, so this was about when fetal pole is present. But if even fetal pole is not present, then you will look for gestational sac and measure the sac diameter. Now, if mean sac diameter is less than 25 mm on TVS, then you have to just choose second scan after a minimum of 7 days. If on TAS, after a minimum of 14 days. But if sac diameter is 25 mm or more and there is no fetal pole, no cardiac activity, then you will again have to go for seek a second opinion on the viability and or perform a second scan a minimum of 7 days after. So like this, you have to take an approach when there is an intrauterine confirmed pregnancy. Let's have a look. A 26-year-old woman, she came at 5 weeks, painless bleeding, 2 days. UPT at home was positive and here also repeat UPT is positive. Since less than 6 weeks, painless bleeding, so you can safely offer her expectant management and ask her to repeat UPT after 7 to 10 days according to the NICE guideline. Here ultrasound scan is performed on a 22-year-old at 7 weeks. She's having mild abdominal pain and vaginal bleeding. Periods are regular and here you find a regular gestational sac with a fetal pole but no fetal heartbeat. So now we have a fetal pole. So now what next to do? You have to take out the CRL, record the CRL, and according to the CRL, you will offer her a repeat scan. So here the answer will be record CRL and repeat scan in 7 days or 1 week since TVS was done. Okay. Last one, here an ultrasound scan to determine viability in a 20-year-old anxious woman denying a vaginal scan at 8 weeks amenorrhea. On abdominal scan, it was found that she had a regular sac with a fetal pole that measured 8 mm, but no fetal heartbeat. So now we have a CRL more than 7 mm, but no heartbeat. So we will try to offer her second scan, a minimum of after 14 days because here it is transabdominal scan, and or seek a second opinion and or repeat. So here the best answer will be seek a second opinion and or repeat ultrasound in 14 days since here abdominal scan was carried out. So hope things are clear regarding this. Now let's have a look at miscarriage. In women in whom diagnosed miscarriage is there, you have got 3 lines of management: expectant, medical and surgical. Now usually if there are no contraindications, woman is also agreeing and there is no increased risk of hemorrhage, for example as in late first trimester, means after 10 weeks you usually don't opt for medical management. Or if there are any prior adverse or traumatic experience like stillbirth, miscarriage, APH, coagulopathies or infection, means on the whole increased risk of mental or physical trauma. Mental trauma like in stillbirth or miscarriage, or physically she will bleed much like in coagulopathy or in late first trimester. In these kind of cases, you won't offer her expectant management. Otherwise, if she is agreeing and if these things are not there, you can use expectant management for 1 to 2 weeks as the first line management strategy. Along with that, give her advice on pain relief as well. Please never forget advice on pain relief as well. Now you will wait and watch for 1 to 2 weeks. If bleeding and pain has not started in this duration, or it is going on and on, persisting or increasing, then that means she's having an incomplete miscarriage sort of thing. Then you will offer her an ultrasound. If an ultrasound abortion is complete, you can exit the pathway. But if miscarriage is either not started or is incomplete, then again you will have to offer her all these three things again. Either you can ask her to continue with the expectant management and again review after 2 weeks of this first follow-up appointment, or you can give her medical management, or you can go for surgical. Remember, here expectant management for 1 to 2 weeks is the first line management strategy. And if her resolution of pain and bleeding is complete, pain and bleeding happened in these 1 to 2 weeks and it's gone now, then you will ask her to repeat UPT after 3 weeks. If negative, well and good. If positive, again the same pathway is to be followed. Okay. And if you are offering her continued expectant management, then you will ask her to review minimum 14 days after first follow-up appointment. This is first follow-up appointment here. After 14 days, again you will call her for review appointment. Now, what medical management of miscarriage is? Always and always never forget to offer antiemetics and pain relief. So look at all the options very carefully, and whichever option says MIFI plus meso plus antiemetics and pain relief, go for that. So in missed abortion, miscarriage, no matter whatever gestational ages, you will use MIFI 200 mg followed by a single dose of 800 microgram meso, vaginal, oral or sublingual after 48 hours. Okay. If bleeding has not started, then you can review her again. Whereas in incomplete, the dose may be either 800 or 600, single dose, meso only, no MIFI in incomplete. And you will ask her to repeat UPT after 3 weeks of medical management, unless the symptoms are worsening. If UPT is coming positive after 3 weeks, you have to evaluate her for molar or ectopic. Now take a look at these options very carefully, and we can solve questions based on this. The first one, a woman has reported to you in emergency with 5 weeks LMP 5 weeks back with bleeding and no other symptoms. Her UPT is positive, her first pregnancy is, it is her first pregnancy. So here, since it is less than 6 weeks, painless bleeding, so again our answer will be same, that is A, expectant management with repeat UPT after 7 days, 7 to 10 days, okay? 7 to 10 days you will repeat UPT. A woman has been diagnosed with missed miscarriage at 12 weeks. 12 weeks means late first trimester. She doesn't want any surgical intervention also. So expectant is gone, surgical is gone, you are left with medical management. So in medical management, the best option was I. Why I is the best option? Because it is MIFI 200 followed 48 hours later by meso 800 plus pain relief and antiemetics. Guys, please never forget to offer pain relief and antiemetics as well. And in missed miscarriage also, you have to offer MIFI. A woman has reported to GP with bleeding, no other symptoms. She is not sure of LMP, but it is around 2 months back. Her examination findings are unremarkable and UPT is positive. Here what you will do, she is uncertain of her LMP. So it's best that you refer her to EPAS or out of hours gynecology service for TVS because she has reported to GP. A woman was diagnosed to have miscarriage at 6 to 7 weeks. This is her second pregnancy, medically fit. First line management strategy, if no specific choice as such, will be obviously expectant management. For 1 to 2 weeks will be the first option, that is C. Expectant management for 7 to 14 days with repeat UPT after 3 weeks. What will be your next step if in previous women no bleeding or pain started in 14 days of expectant management? So yes, Your answer will be offer a repeat scan and discuss all the treatment options again and allow her to make an informed choice. Now, this patient opts for continued expectant management. When will be her next review? So next review was after 14 days of first appointment, after first follow-up. So the answer will be O. Now, if this patient opts for medical management, the regime will be same, that is I, which we have chosen earlier also. And she will be offered repeat UPT after 21 days. Okay. So the answers will be like this. Now, very important are next the abortion clauses and doses. First, let's have a look at the regimes which are mostly followed by UK. In gestational age less than 10 weeks, if the woman is opting for abortion, there are multiple regimes which they follow, but the most common one is 200 mg Mifi followed by 800 microgram misoprostol after 36 to 48 hours. Okay. Some regimes also use 600 mg Mifi, Gemiprost instead of misoprost, but this is the most common one. Between 10 to 23 plus 6 weeks, 200 mg Mifi followed by misoprostol after 36 to 48 hours. The dose will be 800 microgram followed by 400 microgram every 3 hourly until expulsion. Between 24 to 25 weeks, Mifi dose remains the same. 400 microgram misoprostol every 3 hours until expulsion. Between 25 to 28 weeks, it's 200 microgram every 4 hours until expulsion. And after 28 weeks, it's 100 microgram every 6 hours until expulsion. You know, uterus becomes more and more sensitive to meso. So the dose keeps on lessening. Here at the same time, I wanted to give you an idea of what dose of meso is used in IUFD gestational age. At IUFD, in GTG. Okay, so before 26 plus 6 weeks, they use 100 microgram meso 6 hourly, and at 27 weeks or more, it's 25 to 50 microgram every 4 hours. So this we can't help, we have to remember for choosing the best option. Now, much confusion comes in mind regarding abortion clauses. Let's have a look. A 27-year-old primey comes in emergency in an ambulance at 24 weeks. Blood pressure is so high. There is so much proteinuria. She's irritable. Blood biochemistry is also deranged. You commence her on IV labetalol and Maxilf. So here you will have to terminate pregnancy under which clause? So yes, since if we don't terminate her pregnancy, it might be life-threatening to the mother. So either it will be clause A or clause F. Now, if the woman is coming in an emergency, then it's better to go for clause F because F and G pertain to emergency scenarios. So let's have a look. First, we will know like what is A. The continuance, if we continue the pregnancy, the life risk is there to the pregnant woman. To the mother, risk of life to mother falls in A. If it's emergency in F, risk to life of fetus, that is risk to life of child. If the child will be born, either it will be seriously physically or mentally handicapped. So this is E. And if the pregnancy is continued, it would lead to deterioration of physical or mental health of the mother. Means either grave permanent injury to the physical or mental health of the pregnant woman, then it will be B, that is clause B. For example, like diabetic nephropathy, diabetic retinopathy, CKD, or any illness which will further deteriorate, but not life-threatening. Here it will be life-threatening, like Marfan syndrome, where aortic dilatation is more than 45 mm, or pulmonary artery hypertension. These all will come in A. CKD and diabetic retinopathy and nephropathy in B. Otherwise, like rape, incest, where physical or mental health of the mother will be injured, but it's as such not as grave. So then it will be C. Or their mother is not prepared, she's a college student, then also it will be C. If care of pre-existing children is affected, then it will be D. And to prevent grave permanent injury to physical or mental health, if patient is coming in emergency, then it will be G. So let's have a look at few more examples. And yes, clauses A, B, E, under clauses A, B, E, you can terminate anytime, even after 24 weeks. But in C and D, you can only terminate up to 24 weeks, not beyond that. And if gestational age has crossed 21 plus 6, feticide is to be explained. Let's have a look at few more examples. Pre-existing diabetic nephropathy, clause B. Heavy bleeding, she's in hypotensive shock in emergency, cervical os is open, obviously, clause F. It's her 5th pregnancy. Now she doesn't want as care of other children will be affected. It will be clause D. Marfan syndrome, aortic root dilatation, more than 50 mm. It will be clause A. Anencephaly will be clause E because here baby's life is at risk. Pregnancy due to failed contraception, mother is not prepared to continue, clause C. Rape, incest resulting in pregnancy, again clause C. In talipus is no ground to terminate the pregnancy alone, so no clause is applicable as such. Because of girl child, no clause applicable. And again presenting with heavy bleeding in EPAS at night, 6 weeks following rape, and she's crying. So as such, there is a risk of grave injury to the mental health of the mother, and she is in emergency, so it might come in clause G. Okay, so these are the clauses. Now a very important question: RH negative women, when to give anti-D, when not to give. In which of the following scenarios would you not offer anti-D? So here, wherever surgically anything you are doing, you have to close your eyes and say, yes, we have to give anti-D. So laparoscopic salpingectomy, yes. Methotrexate, no. Because medical management of ectopic doesn't require. Medical abortion at 12 weeks is more, so yes. Laparotomy followed by salpingotomy, any surgery, yes. Suction evacuation, it is again surgery, so yes. So any abortion after 10 weeks or any surgical intervention you have to give. Medical management not required. So this is a summary of all the scenarios in which you have to offer anti-D. And yes, where complete mole thing is there, in complete mole also it's safer side. On the safer side, it's better to give anti-D until and unless your histopathology reports have confirmed that it is a complete mole, you will give. If histopathology reports are coming after 72 hours, it's better to give, to be on the safer side. And yes, in threatened abortion, as such, you don't have to give. Do not offer anti-D if you have threatened miscarriage. But if repeated bleeding is there between 12 to 20 weeks, then you have to give at a minimum of 6 weekly intervals. So that's about anti-D. Another important thing is molar pregnancy FIGO scoring and follow-up. So here, suction evacuation was done, histopathology result confirmed a molar pregnancy, serum beta HCG was done, and she presents to you for follow-up. What is the most appropriate duration of follow-up? So either it will be from, if suppose beta HCG would have normalized, then it will be 6 months from the date of evacuation. But if no, then follow up for 6 months from the date of normalization of HCG. So this will be the follow-up of molar pregnancy. 2 weekly serum and urine samples will be done until HCG concentrations are normal. And once HCG is normalized, if this occurred less than 56 days after evacuation, you will measure the urine concentrations monthly for 6 months from the date of evacuation. More than half of all patients will have complete regression within 56 days. But if this occurred more than 56 days after evacuation, means like after 8 weeks, then measure urine concentrations monthly for 6 months from the date HCG becomes normalized. Okay. This scoring is really important. On the basis of this, you can solve questions. Various questions are there. For suppose here, you can calculate the score. 28-year-old woman, she has an incomplete spontaneous miscarriage 3 months ago, and histology confirmed a molar pregnancy. Beta HCG value is this. On pelvic ultrasound, intrauterine lesion, the size is 4.5 centimeter. Otherwise, there are 3 parenchymal nodules in left upper lobe, means chest X-ray metastasis is there. So if we apply the FIGO scoring to this, 28 years age will be there. It was a molar pregnancy, so both these will be 0. Less than 4 months, so 3 months ago, so again 0. Beta HCG values will fit in that chart, and so finally we derive a score of 4. So this patient, she has got a low stage, low risk prognostic score. That's why she will be offered just methotrexate and folinic acid. No need of multi-agent regime. Whereas here, she's 41-year-old. This is one risk factor. First pregnancy, incomplete spontaneous miscarriage 6 months ago. So molar pregnancy, no score, but this is 6 months ago. Then beta HCG values are also more. 5.5 centimeter lesion, chest X-ray is normal. So here, when you will keep on fitting according to the FIGO scoring, the score will be more than 6. So that's why you will have to give IV multi-agent chemotherapy. Okay. In recurrent miscarriage, just a few things have been updated in this guideline, which was not there in earlier guidelines, like which APLA antibody has the strongest association with recurrent miscarriage? So it will be lupus anticoagulant. Okay, this has got strongest association. Next strong association is with anticardiolipin antibodies. Anti-beta-2 glycoprotein 1 antibodies has not got much statistical significance. And yes, which of these disorders is most strongly associated with miscarriage? So out of all these, it is trisomy. Trisomy is the abnormality that is most strongly associated with miscarriage. And then come the others, polyploidy, monosomy, structural anomalies, and so on. Some quick facts regarding thyroid and progestogen. Thyroxine supplementation will be considered with moderate SCH, that is TSH more than 4, but it is not routinely recommended for women with mild SCH, irrespective of TPO status. Means even if thyroid antibody positive is there, you will have a look at TSH. You will give thyroxine only if it is more than 4. TSH more than 2.5? No. Only if more than 4, you will give thyroxine. Okay. If TPO status is positive, you will need to regularly monitor TSH levels from 7 to 9 weeks onwards. Okay. And yes, in recurrent miscarriage who present with bleeding in early pregnancy, just like threatened abortion you will treat, you will give 400 mg micronized vaginal progesterone twice daily at the time of bleeding until 16 weeks of gestation. Okay. Just one thing about nausea, vomiting of pregnancy. If there are any complications, if she is not responding to daycare management, or she is having UTI or ketonuria, then you need to go for inpatient management irrespective of the puke score. Okay? Irrespective of puke score, if any complications are present, be it ketonuria, be it UTI, excessive fever, or any other complication, or if she is not responding to ambulatory daycare management, then you have to go for inpatient management. Okay, irrespective of the puke score. Okay, so that was all, guys, regarding the early pregnancy module. Happy learning to all of you and hope it helped you. Thank you.